Hey guys, welcome to your first lecture, Respiratory Anatomy and Physiology. This is going to be a basic review because I guarantee that since you guys have been in basic and or intermediates, not much has changed with the anatomy and physiology with the respiratory system. However, I'm going to hopefully knock some cobwebs off of the stuff you guys learn in basic and or intermediates and kind of go from there. Okay. I do want to take this time to let you guys know that please make sure you guys are watching the videos that I have associated with this module, specifically the gas law videos. Watch them as many times as you need to in order to grasp those concepts, because you guys will see those on the exams. I'm not going to spend too much time on them during this lecture. I'm going to point out a couple of little things, but not too much. And also, please make sure that you guys are keeping up with your readings that I have for you guys for your weekly modules. It's not a lot, but they are important. You might see some stuff from the readings that are on the exam that I do not cover in class, okay? So please make sure that you guys are keeping up with your readings. As always, you guys are able to email me whenever you want. If you guys have questions, and if it's something big, I'll probably have you guys try to meet up with me on like Collaborative Ultra or Microsoft Teams or something like that, so we can do it face-to-face. Okay, guys? All right, let's get started. Our objectives, what we're looking for is the structures. We're going to go back over all the structures in the upper and lower respiratory tract. Well, I guess I shouldn't say all of them, the important ones in the upper and lower respiratory tracts. Going to move into paramedic land, right? We're going to be really kind of starting to talk a lot about ventilation and gas exchange during this lecture, and kind of solidify some concepts that I need you guys to really remember throughout the semester as we go on, okay? All right, so FIC principle. I'm not going to spend too much time on this because Sean Haverson is going to be doing a online lecture for you guys, a recorded online lecture for you guys on this, from my understanding. If not, I will do the lecture myself and make sure that we really dive more into the FIC principles. But here they are, okay? You guys know the FIC principles as ventilation, respiration, circulation, and perfusion from basic class, all right? These are important, okay? We don't have one of those, we're dying or we're dead, okay? These are very important. Another thing I want you guys to keep in mind throughout the rest of this semester, if you guys haven't heard this little phrase before, respiratory depression leads to respiratory arrest. Respiratory arrest leads to cardiac distress. Cardiac distress leads to cardiac arrest. Okay, so I'm sorry, that was respiratory distress leads to respiratory arrest, which leads to cardiac distress, which leads to cardiac arrest. There it was. Okay, all that stuff's got to be kind of dealt with in a timely manner in order to prevent that. And we're going to start with the respiratory, which is a very important system. Okay, so you guys are looking at the slide and probably see some new vocab or new phrases, new ways of putting things. They all mean the same things, such as the external respiration and internal respiration. Those are still respiration and perfusion, okay? I put those in there because you guys might see these on an exam used interchangeably or possibly National Registry, all right? So, pulmonary ventilation. Ventilation is the mechanical air movement in and out of my lungs, period. That's it, as easy as pie, okay? I breathe in, I breathe out. I breathe in for 2 seconds. I breathe out for 3 seconds. I inhale. I exhale. When I inhale, okay, my diaphragm flexes and pushes down on all my abdominal contents in order for me to be able to get good chest expansion. But my diaphragm actually flexing, that uses energy, okay? So inspiration is an active process. And we call it an active process because it actually uses energy in order to achieve a good full chest expansion, okay? When I exhale, however, my diaphragm relaxes. My diaphragm actually helps push out some of the air along with gravity, so we call it a passive process because we are not using energy, or not nearly the amount of energy that we would be using as if we were inhaling. So inhalation is active, we use energy. Exhalation is passive. We don't use that much energy when we do it. Okay? When we breathe in, we breathe about 10,000 liters of air daily. That comes out to about 500 cc's of gas exchange for each breath, okay? Or tidal volume, what we call tidal volume, right? And we'll talk about tidal volume here in a sec. External respiration is just that. It is respiration. It is gas exchange at the alveoli level. We breathe in the oxygen, goes all the way down our respiratory tract, lands close to the really microscopic capillaries that are basically encapsulating our alveoli. The oxygen is unloaded into our system to be used for adequate perfusion, and the CO2 is offloaded for us to breathe it out. Also remember that we are considering CO2 to be a acid. I know all you chemistry freaks out there are about to blow a pupil, but remember in EMS we considered CO2 an acid from this point out. Okay? When we're talking about transport of respiratory gases, I'm going to talk about this a little bit more in detail on the very last slide of this lecture. On the very last slide of this lecture, there's a formula, chemical equation, I guess I should say, on how bicarb is broken down in order for the waste to be eliminated from our bodies. Okay, so let's back this up a little bit. All right, when we are talking about oxygen or any kind of gas transportation, when we're transporting oxygen, about 90% of that oxygen is actually held onto the hemoglobin on the iron portion of the hemoglobin, on the iron side of the hemoglobin. Okay. CO2 is attached to the hemoglobin as well, but it's on the actual amino acid side of the hemoglobin. And we do have a little bit of CO2 found in our blood plasma as well. Okay. The reason why the body does this is that for the CO2 and the oxygen, since they are on two completely different sides of the hemoglobin, they do not have to compete with each other in order to win the hemoglobin's affinity towards them. All right. So when we're talking about oxygen, 90% of that is on the iron portion of the hemoglobin, where CO2, about 70% of CO2 in our body is actually transported in the form of bicarb. Bicarb is actually converted in the red blood cells by a enzyme called carbonic anhydrase. It converts carbonic acid into the body will convert the carbonic acid however it sees fit in order to eliminate whatever acid it is dealing with. Okay, so here's the deal. Let me just go through this real quick. Your chemical formula for bicarb is H2CO3. I'm sorry. Your chemical formula for carbonic acid is H2CO3. H2CO3 can be broken down into CO2 and water, H2O. Okay, if it's broken down into CO2 and water, the body's going to get rid of the acid, i.e. the CO2, through the lungs. Okay? If we have the carbonic acid, H2CO3, broken down into hydrogen ions and back into bicarb, all right, those hydrogen ions, which is the true acids in our body, if the carbonic acid is broken down that way by our body, more than likely it's going to be eliminated through the renal system or the kidneys, and we're going to pee it out. Okay? I'll get there eventually, and I'll talk about it more when we get to that part of the when we actually have the formula on the slide. All right, and then internal respiration is just perfusion, guys. It's gas exchange at the cellular level, and we need an adequate pressure in order to do that. All right, when we're talking about the upper airway, it's used for filtering, humidification, warming, and transport. We'll talk about those while I'm going over the actual anatomical structures. Here's a picture of your nasal cavity. Okay. Big thing what I actually want to start off with are the nares. All right. Remember that the airways is just an opening for oxygen, guys. That's it. It's just an opening for us to be able to get the gas exchange in and out. Okay. We have the septum. The septum is actually structure for our external nose. The septum itself, about only the top third of our nose is bone. It's connected to the base of the skull by the ethmoid and the sphenoid bone, and if those are fractured, those two bones can actually penetrate the cranial vault and do some serious damage to us. We're going to talk about that more when we get into trauma. And then the bottom 2/3 of your nose is basically just cartilage. Okay, you have all your smell receptors in there from your olfactory cranial nerve 1, olfactory nerve. You guys have already got those in neuro, so I'm not going to spend too much time on that. When we're talking about the sinuses of the nasal cavity, I want you guys to kind of think of the sinuses as they basically are the dump trucks for preventing contaminants of actually entering the respiratory tract. So you guys have a whole bunch of nose hairs that actually kind of help filter and catch the dust before it goes into our airway tract. And the sinuses is where these irritants or dust or particles of whatever are kind of stored, and your sinuses will make boogers, right? Through the mucus, they'll make snot, and you guys hopefully blow it out into a Kleenex or however you guys eliminate that kind of stuff in your life. And then we have the turbinates. The turbinates we have 3 different ones: the superior, the middle, and the inferior ones. The turbinates are actually there for a couple things. They're used to moisten, to provide moisture for the air, humidify the air. They do help to filter a little bit through what's called goblet cells that are found in our nasal cavity. All right, and they warm inspired air as well. Okay, what it also does is the turbinates actually kind of start to spin the air in our system as they kind of enter our nares. It kind of creates almost like a vortex, so that the air is easier to move down the very small kind of cavities that it needs to move through our pharynxes. All right. Okay, let's move on to the pharyngeal anatomy. When we talk about the pharynx, guys, when we talk about the pharynx is actually a generalized term for the nasal pharynx, the oral pharynx, and the laryngeal pharynx all together. All right. We've already gone over the nasal pharynx for the most part. We're going to talk about the oral pharynx. The hard palate is really what separates the oral pharynx from the nasal pharynx. The hard palate is bone. Okay, it helps us chew food, to make food into what's called the bolus, so that we're able to swallow the little ball of food, and it also helps with speech production. Soft palate does the same thing. It can actually, it's got a little play in it, so that we're able to swallow the food that we are eating, and the uvula kind of directs the food and makes sure that it points towards the esophagus and not through the trachea. We'll talk about that more when we get to the epiglottis. The tongue is a very big muscular structure. It's nice and wet. It's nice and floppy. It can be a real hassle for us when we're going to intubate our patients. Remember that the tongue is the number one. Culprit for airway obstruction, right? You guys that snore during your sleep, you guys don't have to admit it, but I'm sure that most of you guys do. You guys are occluding your airway, right? Make sure you guys go get checked, go get a sleep apnea test done, and see if you guys need to wear a CPAP or whatnot. It is an obstruction. You guys are not breathing accordingly, okay? And neither are your patients, right? So if you guys hear somebody snoring, we need to fix it, all right? For whatever reason, my basics always get really confused on that. And I just want to hit that home, make sure that snoring is not a patent airway. All right, so we got the tongue, and then we got the laryngeal pharynx, which we're going to talk about here next. When we're talking about laryngeal anatomy, we have the larynx, which is our voice box. Okay, it's for voice production. Your vocal cords are there. This is really the structure that separates the upper from the lower airways, is your larynx. We have the opening of the trachea. We also have the hyoid bone. The hyoid bone in the picture is that little orangey colored bone on the very top that has the 2 devil horns kind of poking out of it. Guys, the hyoid bone is actually the anchor for your tongue, and your it's a anchor for the cartilage that holds your larynx in place, and it also helps secure the epiglottis to the back of the throat. Okay. So when you guys are chewing food and you guys go to swallow, whether you think so or not, your tongue moves forward just a little bit every single time you swallow. And what that does is when the tongue moves forward, it collapses the epiglottis over the opening of the trachea so that the food has nowhere else to go but down to the esophagus, and it prevents you from choking. So think of the epiglottis as the gatekeeper for the trachea. Okay. You guys have probably seen these before. This is a anatomical view of the airway. You guys have probably seen this while you guys were practicing intubations at some point last semester. The bottom pictures are pictures of you if you were sitting at the patient's head and you are looking down their airway, so the base of the tongue is on the top. It shows you the true vocal cords along with the cuneiform cartilage and the corniculate cartilage. All those are basically landmarks for your intubation. You guys can look that over and read up on those specifically in your book. I'm not going to go too much into it now during this lecture. Here's a side view, and you guys can see the vocal cords very well in that picture on the right. And then here's a great view of a airway. I don't think this is. I'm sorry. This is a. I'm thinking of something else. This is a great view of an airway. I hope that all your airways look like this every single time you intubate a patient. Unfortunately, that's not going to be the case. However, again, those arrows are pointing to the actual true vocal cords, and of course, you want to put the ET tube in between there, right? When we're talking about the trachea, also known as the windpipe, it's about 3.5 to 6 inches long. It is stented open by cartilaginous rings. They're known as C-rings. Okay. The trachea kind of starts right at the top of the larynx there, and it goes all the way down. The actual inferior portion of the trachea is known as the carina. The carina is usually right at about T5 or T7 as far as patient location for our normal adult males. The carina is where the trachea branches off into the right and left main stem bronchi, leading into the lungs. Okay. Another review: right lung has 3 lobes, left lung has 2 lobes because the heart's in the way. So you have a total of 5 lobes for both lungs. The left bronchi is at more of an angle than the right because of the heart. And the carina can also be, there's also a cough stimulation. If for whatever reason we did have particulates or some kind of irritant bypass or get past our nasopharynx and enter into our lungs, the bronchioles can actually stimulate the cough reflex in the carina in order to get whatever's clogging up the airway out, the irritant out. This is a great picture I like to show you guys specifically now, and you guys will see this again when we enter trauma. When we're talking about cricothyrotomy, you guys can see the larynx in the first C-ring of the trachea. So you guys can see the larynx in the first C-ring of the trachea. That little space in between is the cricothyroid membrane. That is where we are making the incision in order to place a tube emergently into the trachea in order to secure the airway. However, you guys can see how the thyroid is laying very close to that, and we'll talk about that later on, but we do not want to nick the thyroid during this process because we can cause some serious medical problems or damage to our patients, okay? And more than likely, you guys will lose your license as well. So anyways, I've never done a cric. I've been on 2 scenes when I was an intermediate where my medic decided to cric. One went very well, one didn't go so well, and it's a procedure that don't really know if I want to perform. I'll do it if I have to do it, but it's definitely something that I'm not looking forward to if I ever have to do that procedure at some point in my career. But again, we'll talk about that when we get to trauma. Whenever we talk about laryngeal bypasses, okay, this could be a laryngectomy or a tracheotomy or something like that, right? This is where we create the stoma in order for our patients to breathe. These can be temporary, these can be permanent, depending on the patient's medical symptoms or diagnoses. I think the picture on the right is awesome. You can actually see where the opening kind of comes out compared to where it is in with the other anatomical structures. The problem when we have a stoma with if it's a tracheotomy or a laryngectomy or something like that is we have completely bypassed the upper airway, which means that we have not filtered, we have not humidified, we have not warmed the air going in. So if these people, this patient population is not taking care of the actual site itself or using the equipment that has been provided with them appropriately, as far as like the filters on their oxygen or ventilation system, whatever they're using, right? We can get some pretty wicked infections with these. And you guys got to think about it, that this is now a direct line to the lungs, right? So if they're not taking care of themselves, they can get a really, really severe respiratory infection. And at times these things do get clogged and we have to go in there and suction them. And you guys will talk about that probably later on this semester. But these can give us some problems. They are awesome if the patients are